Welcome to a basic introduction to mechanical ventilation. This is chapter 1.6, Deadspace. Deadspace. Now in the previous section we spoke about shunt as one of the extremes of VQ mismatch. In that circumstance there is perfusion but there's no ventilation. On the opposite end of the spectrum is time when we have ventilation but no perfusion. This is effectively a waste of ventilation. There's another place where we see ventilation but no perfusion, and this is in the airways. Now, in the previous lectures, when we discussed the presence of gas in the airway and its inability to mix with the blood and exchange gas, we've called this space dead space. In a very similar way, in areas of the lung that have perfusion decreased relative to its ventilation, we call this dead space as well. So as you can see, there are two forms of dead space that we have to understand. First is anatomical dead space, which is air in the bronchus and the upper airways, and physiological dead space that occurs when there's a mismatch between the amount of ventilation relative to the amount of perfusion. This is a high VQ ratio, where there's lots of ventilation but very little perfusion. You can see a high VQ ratio in conditions like pulmonary embolisms, although this is only going to be present for a very short period of time because the body has a way of compensating for this sudden change in VQ mismatch that occurs with the pulmonary embolism. As well, a pulmonary embolism causes other things which complicate the picture. In a previous section, we talked about the consequences of increasing dead space on the PCO2. When the dead space goes up, the PCO2 also goes up. Now, in a normal lung, the brain and the lungs can compensate for this by increasing the tidal volume and the frequency to try and bring the PCO2 back down to normal. When somebody is unable to compensate for an increase in their dead space, whether that be physiological or anatomical, then they have an increase in their PCO2. And so you can expect to see in people who have an increased or high VQ mismatch or dead space, you expect to see hypercarbia as their presenting problem, much more so than hypoxemia. In the circumstances of COPD, you will see hypercarbia because of an increase in the dead space as the alveoli get very large from destruction from emphysema, which also causes a loss of perfusion to those alveoli because the blood vessels are also destroyed as the alveoli are destroyed, and you see larger air pockets within the alveoli that are not close enough to the surface of the cell wall to exchange gas, and this is an effective increase in their dead space. Now, the reason why we see hypercarbia in COPD exacerbations is because the respiratory muscles are now unable to compensate for this increase in dead space and effectively increase their tidal volume and their frequency or their minute ventilation in order to bring their PCO2 back down to normal. When people have a chronic increase in their dead space, such as people we would call CO2 retainers, their inability to compensate over the long term causes them to eventually reset their normal point where they accept for a PCO2. And you can appreciate this as a reflection of the amount of dead space they actually have. So to recap, we can see that on the extreme of VQ mismatch, that's on the opposite end of shunt, is what we call dead space. And this is when we see a lot of ventilation, but not enough perfusion. This ventilation is effectively wasted, and this wasted ventilation, which we previously termed dead space, falls into the category of dead space ventilation, but in the lungs is physiological dead space as opposed to the anatomical dead space, which we see whenever there's gas in the upper airways, the bronchuses, and the trachea, and so forth. You can see classically high VQ mismatch in dead space occurring in pulmonary embolisms, but for a variety of reasons, the compensations and the other complicating conditions associated with pulmonary embolism kind of mask this physiology. And we tend to see an increased dead space condition in patients who all have chronic COPD and have the inability to compensate adequately, and their PCO2 as a consequence increases.